Okay, so Katie, tell us about yourself a little bit.
Yeah, so my background and training is in clinical psychology. I have some specialization in health, and I'm really interested in chronic pain. Basically, my interest stemmed clinically. I've always been amazed by how folks can live with ongoing pain on a day-to-day basis and still find ways to engage and have meaning. I was frankly inspired by this patient population. And so my research is around ways to try and help folks with chronic pain live more fully. And then the other aspect of my research is sort of looking up the line and seeing if we can teach folks some self-management skills before acute pain becomes chronic and see if we can shift those trajectories.
Ruth, can you tell us a little bit about yourself?
Yeah, so the reason that I became interested in pain research was that I did my dissertation work focusing on biomechanics and looking to see how movement patterns contributed to pain. Then in my first postdoc, I was looking at how ultrasound imaging was related to pain. And in both of those experiences, I kind of found that there was always a gap. So they weren't directly linked, there was something missing. And so that led me to seek out my second postdoc here at the University of Iowa with Dr. Sluka, where it was looking at more generally, what are the other mechanisms that are contributing to the pain experience, and how do those different factors relate to each other with and without pain?
That's fantastic. I'm really privileged to be here with both of you guys, and I just say for now, I can't wait to see what we're going to come up with and what the discussion will be like. So Ruth, can you just kind of tell us a little bit about what the questions were, kind of what kind of study it was, and some of the main findings?
Yeah, thanks. So we were interested in this study. So one of the reasons I was interested in studying patients with Achilles tendon pain is that about 40% of patients who seek care, either non-operative or operative, continue to have pain afterwards. And currently the standard of care is really focused on peripheral pain mechanisms.
So this study builds directly from a review paper that Dr. Chimeni published in Physical Therapy Journal in 2018, where she reviewed nociceptive, nociplastic, and neuropathic causes of pain, where the nociceptive cause of pain is a peripheral mechanism from sensors in the Achilles tendon or peripheral areas, and nociplastic pain is from central mechanisms such as psychological variables or central processing that's occurring to cause pain.
Peripheral pain mechanisms, what we are interested in there is that a lot of times there are kind of two beliefs about what drives Achilles tendon pain. So one is that it is a peripherally driven pathology, so where the pain is localized to the Achilles tendon and is driven by pathology within the tendon. And that's the standard of care has really been targeting that.
For an insertional tendon.
Oh yeah, so with insertional Achilles tendinopathy, they had localized changes of the tendon itself, so it was thicker, and in addition, they often had retrocalcaneal bursitis is a little. I guess I can say that even though it, may not be detected on imaging, but when they go in to do surgery, so they may have had nobody in it actually had like full blown bursitis that you could really see on the imaging, but a lot of them did have probably Haglund's deformity, and as well as osteophytes, which you could see really well on the ultrasound imaging. And then for mid-portion Achilles tendinopathy, the majority of patients, they just had the classic thickening of the Achilles tendon in the region where they were having pain. And so that coincidence of pathology with the site where they're having pain lead to most of the treatments really focusing on those aspects.
Okay, and that's so then how did central processing come into this?
Yeah, so about 40% of patients continue to have pain after these peripherally directed treatments. And so that led to the hypothesis that there may be other factors that are involved within the central nervous system that are contributing to pain. And the factors that I was interested in were, first of all, looking to see at movement patterns, and how that was affected. And then also using quantitative sensory testing to look at patterns of decreased pressure pain threshold, increased sensitivity, and then also looking at psychological factors, particularly pain catastrophizing and kinesiophobia.
I see. So you have these kind of three elements, right? You got the movement, which could be influenced by either peripheral or central, right?
Yep.
And then you've got the pain, pressure thresholds, and I think you had some summation.
Mm-hmm. And temporal summation and conditioned pain modulation. So kind of a pressure pain threshold, which is kind of more static, and then the temporal summation and conditioned pain modulation are looking more dynamically how the central nervous system responds to a sensory stimulus.
And so those would all give you indications of central processing.
Mm-hmm.
And then you had the psychological variables, which were really, again, you don't really know, but they're obviously central because they're cognitive more than they are peripheral. So tell us what was the experiment in essentially trying to tease out, because I mean, it's not that easy to shut down peripheral stimulation, right? So in this experiment, you did that.
Yeah, so it was a repeated measures study. So we had participants come in for a single visit, and they completed, these 3 different measures. Then we had a physician come in. He did an anesthetic injection to the region that was most painful in the Achilles tendon. And the level of the anesthetic was about equivalent to the amount of anesthetic that they use when they go in to do a localized procedure in that area. And then they repeated all of the tests again. And we looked to see if they changed with the anesthetic. And the model is assuming that we've knocked out that peripheral nociceptive input. And then that was a way to see if that peripheral nociceptive input would then, if we were able to knock that out, if that would then also reduce these alterations in central processing.
So let me just kind of play it out. So essentially, if their central processing was driving some of their symptoms, even after the anesthetic, they would have continued to have localized pain in the heel and over the insertion or the mid portion, and then that would have told you, well, okay, so it's really a central processing that's driving it, right? Okay. So what did you learn then after the injection? What was the gist of the results?
Yeah, so what we found was that with the anesthetic injection, as expected, they had less pain with movement. And then in terms of the quantitative sensory testing measures, there was no difference before and after the anesthetic injection. And then for the heel rise performance, so looking at motor task performance, we looked at 2 different tasks. We had stair ascent, which is a little bit of a lower level task, and we found that really didn't change before and after the anesthetic. And then with the heel raise, single leg heel raises, which is a little more challenging, that's where we saw our biggest effect and biggest improvement in motor function with the anesthetic. And in terms of psychological factors, we also saw differences over time. Once they had the anesthetic injection, fear of movement and pain catastrophizing decreased.
So those are the measurements themselves, but like in terms of your original hypothesis, so sounds to me like peripheral mechanisms really govern a lot of the movement dysfunction.
Yeah, and as right? Well as it seems like they're also driving the psychological factors as well. So once you wiped out the pain, mm-hmm. you essentially wiped out the pain catastrophizing.
So what we're really arguing is that essentially the nociceptive or peripheral input was the main driver between the patient's pain experience, their motor dysfunction, and then some of the psychological variables. So let's cut to a case that illustrates this.
So Ruth, you prepared this case for us. So why don't you go ahead and talk us through this, and then maybe we can hit some psychological approaches to treating this patient. Right?
Yeah, so this was a man in his 50s who, when I did the ultrasound imaging of his Achilles tendon, he had a really thickened tendon in the mid portion of the Achilles where he was having pain. He didn't, as you can see, didn't have much pain with heel raises, but he also couldn't do any. So I have a video, and in this video, he's trying to do the heel raises and his leg is like shaking. He is trying so hard to do the heel raises. He says it doesn't hurt, he just can't do any. His pain is most aggravated with walking. He enjoys golfing. And I remember he was talking about how he when he went out golfing with his friends, now he had to take a golf cart so that he could do it. And so he missed out on that social interaction because he was in the golf cart. And you can see that when I tested him before the anesthetic, he wasn't able to do any heel raises. And then getting a little bit into the biomechanics here, he had his max ankle power was during push off of 1.3 watts per kilogram. And then in terms of the psychological measures, he had high fear of movement. So there are different cutoffs for the TSK 17 item version. Some are 37, some say 41, but he's definitely has high fear of movement. On the pain catastrophizing scale, he had a score of 13, and so a cutoff of 30 is typical to say that someone has high pain catastrophizing. And so he does not really have high pain catastrophizing on that scale. And then after the anesthetic, maybe I should hop down to, he was then able to do 18 heel raises on his painful side. And he had absolutely no pain with it.
Yeah.
His ankle power improved just a little bit with walking, doing the stair ascent, and again, absolutely no pain with doing that. In terms of the psychological factors, you can see that his fear of movement went down a little bit, a relatively small percentage. So it went from a 47 to a 41. So it's still elevated. It's still in that elevated threshold. And then in terms of pain catastrophizing, it's now dropped to nearly 0.
Right, which was, I think, one of the more interesting parts, and maybe Katie will jump in on this too in a minute. But what seemed to be really interesting to me was this dichotomy between one of the psychological variables got wiped out, but not the other one. So catastrophizing really was immediately done right after the injection. The scores went right back to normal, but the fear remained. Mm-hmm. And even though it was a little bit decreased, it was still elevated at the long term, or what was the long term? It was like a week follow-up or something.
Yeah, and then we did a 1 week follow-up, and that was primarily put into the study because we wanted to check up on them after the anesthetic injection to make sure there weren't any adverse events.
Right.
And so we're screening to see what is your pain level? Have you had any redness around the injection site? Those sorts of things. And then we also had asked them about their pain catastrophizing and had them rate that at 1 week later. But we just chose one because we were trying to keep it brief over the phone. But now going back.
So you didn't get fear. You didn't get fear on the 1 week. You just know. Okay.
Just pain catastrophizing.
So what I'm hearing is that was an inadvertent finding a little bit.
Yes. Yeah. I was not
This is unplanned.
Catastrophizing to continue to be reduced at the 1 week time point.
Okay. All right. I'm going to pin you. Oh, so Katie, so we just heard Ruth kind of summarize her study. And so one of the things that's interesting, she had these 2 psychological variables, one being the Tampa kinesiophobia scale, which measures fear, and then the one being pain catastrophizing. So after the injection, the fear remained, but the pain catastrophizing was really normal. So what's the difference in those scales? What are they telling us psychologically that's important?
Yeah, so it's a really great question. There's certainly some overlap between the scales. The catastrophizing is really about pattern of thoughts around pain. And you've got a helplessness subscale, a rumination, and a magnification subscale. So it's this hyper focus on pain and worry about it. The kinesiophobia scale, has a lot of some fear of pain, but it also has some fear of movement. And also, if you look at the individual items embedded in there, there are some items about intent to avoid behaviors. So it has this sort of behavioral avoidance component woven in, which is a little bit different than strictly just the thoughts about how bad pain is. So I would sort of distinguish them that way.
So when they talk about the fear avoidance theory, the avoidance measurement, the Tampa may, kind of capture this avoidance in there more, where the pain catastrophe scales assumes that because there's these negative thoughts and beliefs and rumination going on, that avoidance would follow, but it doesn't necessarily measure that. Is that true? Okay.
Right.
Got it. Okay.
There's some overlap between them, but grossly, yes, I think that makes sense.
Does that make sense? So what do you think is, what do you think is the main explanation for the difference here? Like, why did catastrophizing disappear and fear remain, basically?
So it's a good question. So I think a couple of factors to look at. Catastrophizing was quite low in this population. Pain levels were relatively low at baseline. The fear of movement was higher than catastrophizing. They're on the same scale, and catastrophizing was in the teens, and the fear of movement was in the, I think, 30s, if I'm remembering correctly. So I think just noting that to begin with, I would be really curious if the results would look exactly the same in a sample with folks with much higher levels of catastrophizing, if the results of the injection would be exactly the same. I don't know. It's an empirical question.
Right.
With oh, go ahead.
Yeah. So I was going to say, so I love that, because it's like it makes this nuance that, peripheral, like extremity types of problems may be, because I think where we see the higher scores is like really with low back pain or more acute problems or something like that, where a chronic overuse injury like Achilles tendinopathy is really, when you rest, it doesn't hurt so much. It only hurts more when you're active, right? And that's kind of partly what we're getting at, is they can avoid the pain pretty easily. And so catastrophizing is not that high to begin with, versus fear, when they know they're more active, they're going to induce this problem, and they're kind of relating to that and cognitively. So, all right, so let's switch gears to psychological frame. So one of the questions that I think is interesting, let's go back to an overall view before we do. Okay, here we go. So Ruth, when you pick these, so I'm going to have her talk about how she picked them, and then we'll go to the frame. Okay. So Ruth, when you pick these two variables, these two psychological variables, how did you decide on these two versus the other? There's a lot of psychological variables to pick from that are related to performance and things like that. So why these two?
So I was interested in fear of movement, and there was a previous study that had showed by Karen Silvernagel that had showed that patients with a higher fear of movement using the Tampa scale of kinesiophobia, that over a 5-year follow-up, that they had regained less calf muscle strength. And so I was really interested to see, how would this be related in the current study among patients who had high fear of movement, to see if they, regained less calf muscle strength in a really short period of time.
So from a research standpoint, it's because it's already been documented in this group, and that really no other psychological variables had. Plus, it sounds like it kind of related to this idea of central processing versus peripheral processing. So that was it sounds like that might have been attractive to you. Yeah. So let's switch now and ask Katie, like, how does this fit into, there's lots of psychological theories that, tell us more about the interaction of these variables, because treating patients, after all, we have to take these psychological things, if we're going to do that, and then address them in some other framework, right? Not just in isolation, right? So how would you fit this into a broader psychological model?
Yeah, so I think we talk about the fear avoidance model a lot with musculoskeletal pain in particular, right? And this idea that there's fear and then activity is avoided, and then pain increases, disability increases, and you're trying to sort of break in at some point in that cycle. And I think one of the things from this is if you can just take away the pain, great, that seems to be a big help. But even with that, when you've got sort of more of an episodic pain condition, there can still be this fear of movement, this avoidance of movement. And I think from a clinical perspective, one of the most interesting findings I thought from this study, it's kind of a smaller one, it's embedded in the paper, but there's a correlation between, I think it's when the heel raises, so the performance on those after the injections correlates with decreases in kinesiophobia. And if I read it correctly, Ruth, they do the heel raises first and then the surveys. Is that correct?
Yep. And
so
yeah.
I was thinking of this as like a mini exposure session, essentially, where they're afraid to do this activity and then are able to do it without damage, and we see that little decrease in their fear of movement from that point. And I think that's actually really critical from a clinical perspective in terms of sort of how to make inroads with this fear avoidance model.
So for you, Katie, this idea of exposure seems to be really important, right? So help us understand how would you define exposure, just short version, and then how does the heel rise fit that?
Yeah, great question. So we develop anxiety or phobias around things when we pair a fear with a non-dangerous stimulus or activity or whatever it is, right? And to sort of unpair that connection, if you expose somebody to the non-dangerous condition or exercise or whatever it is, and then they have the experience of being able to do it without it causing harm, then it starts to shift that fear and anxiety around that. Right. So in this group, there was this fear of movement, heel raises, as I understand, being more intensive for this particular clinical presentation and really pain inciting. And so being able to engage with them and have that be a non-damaging, non-harmful experience then can shift the psychology a little bit around thinking about how much do I need to avoid these in future? How afraid of this am I?
So just to kind of keep with this psychological theory, so essentially they're having these negative thoughts about anticipating this fear is occurring. So to restructure that thinking, they have to be exposed to it, not have the negative outcome, and then the thought will automatically disappear, or
it starts to shift a little bit. Right. So what happens when you don't engage in the activity is the fear increases, you avoid it, and you feel a little better, right?
Yeah.
So that builds this idea of it must be scary. It must be something I need to avoid. Avoiding it seems to be a really good thing, right?
Right.
And so when you start to engage with it and doing it in sort of a manageable chunk so that it's tolerable, essentially, it starts to build up a counter experience of, oh, maybe I can do this.
Right. This is good. So so that's great. So that's kind of, and I think this has a name, this approach. Is this fit CBT or does this fit?
Yeah, this fits within cognitive behavioral therapy. Yeah.
Okay. So that would benefit. Okay. So that's kind of what we're talking about. So let's break out now and I want to go back to something that's popular in the clinic right now, which is neuroscience pain education. So we have this idea of CBT, because that's our frame right now for psychology. We kind of know what's going on a little bit from Ruth's study with pain catastrophizing and fear, and it's more about fear. And so what we want to do now is think about how we would approach these patients, right? And so one option that's come up because of the testing is this idea of exposure. And so another option is neuroscience pain education. And so Ruth, you've been doing that a lot. Is there an opportunity for that here, or how's that contrast with exposure, basically? So let's do neuroscience pain education first, and then see how it contrasts with exposure, because they're different, right? Or no?
I think they can be potentially complementary.
So, sure, but if you do the education without the exposure, do you get the same reduction in fear?
Good question.
So from what I've read on this, building
I think I'm actually gonna keep that in, right, like that. So Ruth, what do you think? So I mean, let's have a discussion about this, because I think one of the things, I'll just tell you, I have some reading on this, right? So Peter O'Sullivan did a project. He did a couple projects where he measured pupillary dietary responses and sweating and heart rate by exposing people to pictures with people with low back pain where it hurt to do bending, all kinds of pictures and diagrams of bad, dangerous activities, and he couldn't elicit any fear responses. And he did the same thing with spiders. He calibrated it with really snakes and spiders, and then pleasurable things like ice cream and beautiful beaches and the Caribbean. And basically, despite calibrating it, he couldn't elicit any range of response in comparative pictures, right? So the assumption was that you don't really elicit fear with education. And then there is studies like Traeger and JAMA, like I think 2019, just showed that like a compassionate discussion in comparison to neuroscience pain education with nothing else, doesn't really have any effect. And so there is some data out that suggests that education alone doesn't work. Now, it's in low back pain patients and it's different. But so anyway, I'm just trying to get some take on how it may be important, basically, that neuroscience pain education has to be paired with exposure somehow to make it work out. So I just thought we might have that discussion. So Ruth, now that you've heard all that, what are you thinking?
Thanks for the lit review. Yeah, so as I was listening to Katie, I thought it was really interesting in terms of her point about how this graded exposure could be contributing to our improvement that we see in physical therapy with this patient population. So right now, the standard of care is really a progressive tendon loading program. Mm-hmm. And so we don't really know, is it really the primarily the physical effects that we're getting the benefit from, or is it this, progressive graded exposure that we do where it's like, oh, okay, so you're able to have manageable symptoms while you're doing this level of the exercise. Let's try bumping it up and see if, you can still keep your symptoms within that range.
I see.
And in terms of thinking about how that relates with pain education, is that, so when I was looking into designing my current clinical trial, that includes pain education, exercise, initially I was thinking of trying to see what is just the effect of pain education, and then what about when you combine them. But it seemed that the effect of pain education on its own was not going to have a dramatic effect on the physical function. And so it can be enhanced when you combine it with the physical exercise piece.
So just to be clear, effect. I just want to make sure I'm hearing you right. So you were trying to do pain education alone and just at a pilot level?
No, I was just considering it.
Okay.
And then when I was looking into the literature and also advice from collaborators on the project, so Lorimer Mosley was like, I wouldn't bother trying to look at just the effect of pain education. And then because I don't think it's going to have a dramatic effect. And then later on, a few years later on, all these systematic reviews come out and show pretty small effects of pain education alone. And it's really most effective when paired with exercise. And I do think that, potentially the psychological impact of pain education is you need to have it paired with that graded exposure. You need to have it paired with, some other physical activity in order to apply it and to get the effect that you want.
Okay, that's great. So Katie, that kind of agrees with you. So how does a clinical psychologist do graded exposure for something like this?
Yeah, so it's a great question. I will say that in all my years seeing folks with chronic pain, I don't know that I've ever seen someone just presenting with tendinopathy. So I will state that as a disclaimer.
That's a fair statement. Like Ruth and I are foot and ankle specialists, so we hear this all the time, right? That we see 5% of the patients in the clinic, right? But anyway, go ahead. So how? But you can actually have freedom to speak with chest pain or total knee, whatever you want. Just.
And most of my folks in the clinic hurt in a lot of places in their body by the time they come to me. So I've probably had folks with tendon pain and lots of other body pains.
Yeah.
So I think what psychologists do, one, we love it when our patients are seeing physical therapy as well. That's always a plus for us. And when it's in an institution where we can communicate with one another, so much the better. So if there is a PT regimen, we try and incorporate and work together.
So,
whether there is,
but I have a special interest here, so sorry for interrupting, but yeah. What do you think if so what I'd like to do is have us share some of our like superpowers, basically.
Yeah.
Right. And so like, it would be nice if we could give you some movement strategies, so you could do some work with exposure and movement, but also you give us some of your skills, basically, in terms of psychology. So what would like, if you were going to do this with heel rises, what would you need from us to treat a patient like that, to do the exposure, like to make you feel comfortable? Like what kinds of skills, like, and things might you want from us?
I think just some training, like how to talk someone through it, how to demonstrate it, what we're looking out for. Like, these are the signs that you should have them stop doing it, versus these are the normal, it's going to be uncomfortable and they're going to say things signs.
Right.
I think psychologists typically default to walking. We want to get all our patients moving, and we either send them to PT, to the pool, or we have them walk.
Right.
Because that's where we feel comfortable.
But the problem with that, the exposure's less, right? So you can't address the real fears that they have. And so by staying in the safe zone, you kind of guarantee this kind of ceiling effect in your in your treatments, right?
Absolutely.
Yeah. So what about Ruth? What questions do you have for Katie in terms of like what do you want from her to know how to like talk to the patient or push them, or like, like in this particular example, like what would you ask her about, like if you were going to wipe out fear, because you didn't really do it with the anesthetic, what would be the key in like getting rid of the fear in these people? Like, like how does that work, like for you, Ruth?
Let's see here. So I guess one of the things that I struggle with knowing is what piece of the puzzle is going to be most influential for improving their physical function. Is it just purely they need pain relief? Is it that their fear of movement is driving it? Is it pain catastrophizing? Is it, depression, anxiety? Is it, like trying to figure out like, which of the psychological pieces are most important for this person, and how do I know which one to focus on, or even how to focus on it? So if they have high depression and anxiety, I'm not sure how to address that as a physical therapist.
Yeah, I think the beauty and the difficulty is that a lot of these things are bi-directional or multi-directional, right? If we can sort of get in on one piece, often it connects to the other pieces. And I tend to think about, first of all, figuring out what's really important to the patient, right? What is going to make their life more rich and meaningful? And then everything anchors to that, right? And if I keep trying to do something with a patient and they're not, doing their homework or engaging, or sometimes that's a flag to me that I've missed the boat in terms of what they actually want. So it's always about what's important to them. And then this idea with fear, this idea that we have to be not afraid to do things is sometimes a misfit with this work for our patients, right? Bravery is sort of doing things in the presence of fear because they're important, right? And actually, we're asking our patients to do lots of really scary things. And I think when we acknowledge that, that's sort of important, right? Especially if it's paired with, you've told me this is really important to you. And it seems like the way to get there is through doing some really difficult, scary things. I'm going to be with you. We're going to do this in a manageable way. And I see how hard you're working and how scary this is for you. And that makes sense, right? And do you think we could start trying some things out?
This is great. So basically, I heard you say a couple things. And Ruth, what did you hear? I mean, well, here, I'll do it. I heard you say safety. When you expose them, they have to feel safe and reassured, and then incremental. So that part of it's important because we're not sure which ones are most threatening to them, because different things could be threatening. Then the second piece was it has to be really meaningful to them, or else why would they push that hard? So even though they might feel like they could do it, if they don't really want to do that, well, then it's not going to match up. They're not going to push through that. Well, let's do this now. Like, if you guys are open to this, let's take this case that
Well, can I do?
Oh yeah, you go ahead. Yeah, go ahead.
Yeah, so I also thought it was interesting your point about if a patient is not adhering to the exercise program, to reevaluate your exercise within the context of their values. And so as a physical therapist, I'd say that thinking back to when I was in the clinic, it was very rare that I had a patient who was compliant with all the exercises and didn't get better. It's those patients that don't comply with your exercise program. You're like, well, I guess I gotta give them different exercises, or, and so like considering it more in terms of linking it back to what they really value, and acknowledging, if it's the fear of movement that's holding them back from doing that particular exercise, or maybe I haven't framed the exercise in a way that links it to the things that they value. It's a really interesting point.
So Ruth, how many times do you think that you, or me, like I'll even myself, you made your goals for your patients 100% from the patient? And how many times did you do 50% from you and 50% from the patient?
Yeah, I would say probably more the latter than I'd like to admit, because you think about, whatever your standard is in your own head, and you want to get them to align to your standard, your goals.
And it takes time, right? I mean, Katie, it takes a long time to find out what they really want. How many times do you typically have to ask a patient why they're there when you treat them? Like, how many times?
It's an ongoing conversation, and you sort of pick some initial points and then you recalibrate as needed, right?
Yeah.
It depends on the patient. Some people have a clearer sense, but for some people, a big part of the work is just figuring out what they want, what's important to them. And the other piece that can come up is there can be costs to improving functioning, right? Like if I start being able to walk again, I might have to go to work, or I might have to start running around for my kids. And actually, it's been kind of a nice break, right?
Right.
So kind of trying to elicit some of the, what do they want and what does it mean if they start to get better, if we use that really broadly.
But they may also have changed their values, right? Because their old values may be strong, independent, and their new values may be dependent and weak, right? So you have to kind of help them rediscover their old values maybe too.
Yeah, and sort of figure out who they want to be from here. I talk a lot about, you've been walking down this road, especially for folks who have had like a pretty traumatic accident or injury. You're going down this road, living your life, and suddenly a brick wall has fallen in front of you, and that road is blocked, right? And you keep trying to reach back to like, yeah, but I used to, and here we are now, right? And we're gonna have to figure out if we want to turn right or left or start digging a hole or what we want to do, but it's going to be different, right?
Yeah.
And sort of from here, who are you? What is important to you? Who do you want to be?
Well, that's great. So Ruth, do you have anything more on that?
No, not at this time.
Okay. So what do we, can we end? So this is, I don't know about you guys, but I think this whole setup is amazing to me. So can we do a case and then just like use that to like wind it out? So, all right, so let's go to a case now. And Ruth, let's see, oops, where's Ruth's case? Let's see, let me give it one more screen share. Do this one. Okay, right, so let's shrink this down. Okay, here's Ruth's case. I mean, it's important right now that we define the difference between, pain catastrophe and fear, because it's a central finding for you. So do you want to do it and then Katie jump in, or how do you want to do that?
I'm happy to let Katie do that.
You can do that.
Yeah, do that.
had another thought too, as Ruth was talking, just process-wise.
Yeah.
I think this might be a lot more accessible for PTs if I just talk about this from a CBT fear avoidance model. Because if I go in with ACT, I'm going to have to translate it out of one model into another. And I think it's going to be a little harder.
Whatever you want to do.
Okay.
I do think what you do, whatever you would do clinically, like if you would, I want PTs to leave with something they can say, okay, how would I use it? So whatever you want to do, and I'm happy. I don't need to stay in ACT. I'll stay whatever you want to do. So if you do, because you've done both, like do you use? Okay.
I use both, and I do research in both.
Okay.
And patients don't care which one you're using, frankly, for the most part.
Right. They just want to be better, right? Okay. All right. So, So I'm gonna pin you now, Katie, and then ask you about this pain catastrophizing versus TSK scales. Like, would they pick up different? Like, what did Ruth pick up here that was interesting from a psychological point of view? And then we'll go into the frame. So we'll do the CBT frame then.